I'm Stephanie Shelton, and this is episode 36 of Conversations on Health, How We Get There. The cornerstone of any healthcare system is the general practitioner, or GP. In the U.S., we've renamed the GP to the rather cold-sounding primary care doctor, perhaps because so few of us still have that old multi-year connection with our doctor, or perhaps because of the way our huge health insurance companies function. In the last podcast, episode 35, we talked about the UK's still ailing health system, the NHS, a year after the Labour government took over. Not much change yet, but a recently released 10-year plan envisions most standard healthcare centralized in neighborhoods at the GP level, including the mushrooming varieties of medical imaging. Now, this doesn't sound particularly revolutionary, especially if you live in the Czech Republic. Healthcare there still revolves around the general practitioner. So, we're going to meet a longtime GP in this episode who also teaches and is involved in many international healthcare projects. In addition to his MD, Dr. Bohumil Seifert also holds a PhD and is an associate professor at the Institute of General Practice, First Faculty of Medicine at Charles University. He headed that department for 14 years until 2023. Dr. Seifert now spends half his time practicing in central Prague, that's the Czech Republic's capital, and the rest of his time is spent in international activities and research, much of it for the World Health Organization and WONCA, the World Organization of Family Doctors. We used first names in this interview, as is my custom on this podcast. Bohumil, thank you so much for coming on the podcast. I'm really appreciate it.
Good afternoon. I'm pleased as well.
Can we start off by just a short review, because we did the Czech medical and health system in my very first podcast, and that was 3 years ago. A very short review of how the Czech system works in terms of GPs, as you are, and hospitals, and how it's connected.
Yeah. I would start with that Czechia has gone a path in terms of development of healthcare system through the Bismarck system, then through socialistic state healthcare to the reform system financed by health public health insurance, and all the time the strong role of primary care and prevention was maintained. So now the system is financed through public health insurance companies, and primary care providers operate as independent contractors of insurance companies around the country. So we have quite a stable network of general practitioners around the country, the network that has been developing for almost 50 years. They work completely independently from hospitals.
Okay, so the insurance companies, I mean, when you say insurance companies to Americans, they just want to start crying, because we have constant battles with insurance companies which don't allow procedures or don't allow medication or whatever. Are your insurance companies private or quasi-private, part government, part private?
This is the second case is true. They are controlled by state. They're partly owned by state, and their independence is limited. So they have to follow the law and the regulations, which is done by state. They have some special programs, bonification plans, which can differ somehow. But in general, they do the same. We have now eight insurance companies that were developed according to different directions, like the military-oriented insurance company, where mostly military people were insured, and we have general health insurance company, which is completely run by state, and it has around 70% of clients. So this is how the system looks.
So in a sense, the insurance companies are running the healthcare system for the government. I mean, somebody has to implement the government laws and regulations and
Yeah.
so on. So and in the UK, for example, the NHS is the one that implements it.
Every year there is a discussion about prices because it's about money, of course. Yeah. So state is one of the partner of the key partner of insurance companies when they negotiate prices for healthcare. Yeah.
Um, so how is the Czech system holding up? I mean, everywhere I look, we have this huge wave of baby boomers retiring. And many of them are retiring sick. I mean, they have some kind of diseases, something they carry with them, or if they don't, they will be very quickly having some problems. I would say most of what I've seen and the people I've talked to don't really know what to do about the financial aspect of that because it's going to be very costly for literally every healthcare system.
Absolutely. I think we are facing similar challenges as in neighboring countries, like aging of population, increase of polymorbidities and chronic multimorbidities, and of course lack of staff and general practitioners in rural areas. And especially the system is under the pressure with the increase of chronic care. That's the main problem. Yeah.
Um, is it possible to sort of balance that if you can work on prevention with younger people so that, yeah, most of the money will go to older people, but at least it won't keep happening. I mean, if the baby boomers, they're such a big group. So in our country, they retire at 65. You're eligible for Medicare at 65, which is our government run program for older people that we contribute to for all our working lives. There's still this huge group behind where some kind of intervention, preventive intervention, might help. Is that possible?
Yeah, the Czech healthcare system is very oriented to prevention, especially general practice, in fact, as a hub for prevention. We do regular preventive check, and now we rely on them that they would help us in early detection of people who would develop chronic care later, and so that's the first thing. We do a lot of screening programs. We have now 5 cancer screening programs based in primary care, in fact. And then we also have another program of early detection like dementia, osteoporosis, and so we do a lot of prevention, and I think we are just at the edge or it's hard to balance the need for prevention and need for acute care and chronic care, because better and better we are in prevention, more and more people we have to follow up and to treat, and they in fact they fall to the regime of chronic ill people who need follow-up. So that's we are just in this crossroad, if we go more further, because the problem is a capacity of primary care, capacity of each practice, and capacity of primary care in general. Yeah.
Well, then we're all in the same boat in a sense,
Yeah. Yeah.
which doesn't help any, but at least we know we have friends.
Yeah.
You talked about when we were just talking about pre-discussion here, how you make your money as a primary care physician. In our case, we pay insurance costs, and our insurance companies reimburse the physicians or pay what they allow for a procedure or for a visit or whatever. In your case, it's more specific than that, right?
Absolutely. We are very social. As I mentioned, the Bismarck system. So the basic principle is that everybody who is in productive age and work pay his insurance, pay to his insurance company, and state add another money to insurance company, and state also pay for all pensioners, for young people, for people who study, and so that's how the budget for the health is happening. And then I, for example, as a GP, so I get my money part from capitation payment. So we have indexed capitation, so it means that for young people we get less, but for old people we get like 3 times more. It's about the consumption of care. So we have 50 to 80% of income of practice comes from capitation fee, which is paid on monthly basis and starts from the moment when patient register with my practice, and then the rest, less and more, we get from the like fee for service, from the preventive care, for the house calls, for the special
House
procedures.
calls? You make house calls?
Absolutely,
Oh, that
we need to we have to make house calls as a kind of our as a part of our duty. But I can tell you, when I started my career as a GP, I did like in the very in the urban area in the very center of Prague. So I did like 60 house calls a month. Now we have 3 times more patients and we do like 20, 30 visits per month.
house calls are a dear departed dream for Americans. I can remember when I came to New York, I was in my early 20s and I got the flu and I thought I was going to die. And I called my doctor up and I said, please come. And he said, no, no, you just, take aspirin and you'll be fine. And I said, you're going to let me die? He said, you're not going to die. And that was the end of it. And that was when I realized that the house call world was over. Because when I was a little kid, my pediatrician, everybody's pediatrician, made house calls. It was a normal thing. It's just gone. You can, there are certainly housebound people who get care, but I don't know too many doctors who would ever have time to make house calls because the insurance companies basically want you to spend about 15 minutes with everybody.
Yeah,
And you can't do much in 15 minutes. Certainly not a house call.
yeah.
So maybe I'll just move to the Czech Republic permanently as I get older and older.
Well, there are 2 reasons for house calls. Maybe half of them are really for acute care, but they are more rare and rare. And the second half, or the second reason, is that I from time to time have to see seniors who are by home care, who are insured by home care and social care. So I have somehow to coordinate the care. So I do this visit like twice a year or something like that. Yeah.
Wow. Well, that's interesting. It was a wonderful thing in the days when there weren't so many of us, but um, you told me, I think, that almost everything is centered at the GP level, in the sense that almost everybody in the Czech Republic has one. Well, what was it, 90%? I think you said.
Yes,
Does
yes.
that include younger people?
Uh, I think about 90% of people really are. The registration is not an obligatory act.
And
But
excuse me, when you say registration, because it's not a word we use here, what does that exactly mean?
that means that to use the system effectively, you are supposed to have your own GP. You have free will to choose your GP, and it's a formal act. Even you sign some paper, and from that moment you become a patient of this GP or of this practice. Practice start to get capitation fee, and patient knows that in case he has his own GP. And the reason why people adhere to GP and adhere to this registration is that the registration is a gate to the real gate to the prevention, to screening programs, to guidance through the system, to rational use of specialists, and two different, we do a lot of administrative things like driving license and another
You mean the vision test or something?
yes, something like that. So we do a lot of things which people need, so they need to be registered.
That's interesting because some of the older people that I know in the Czech Republic spend huge amounts of time going to see their doctor at a hospital, not in their doctor's office usually. But they get it's like a clinic. They get a time to come in and everybody gets the same time, and then it's kind of first come, first serve. Do your patients work that way? I mean, we just get in when we go, we get individual time slots, and that's it.
Our system is far to be optimal. So in fact, we have free touristic for patients through the system. We have no strict gatekeeping. But but I told you last time that even it's not obligatory, 90% of patients search for care via or through the GP. But they don't have to. They can go directly to specialists, and usually they are accepted. Now the waiting times are longer and longer, so it's becoming more and more difficult for them. So that's why also we need to enlarge our competencies, because we have to do more things, at least in time, before they get an appointment with the specialist. And people travel, and we still do not have sharing of electronic data. So it's
You
happening.
mean in the Czech Republic or within the EU?
I think in Czech Republic, there are some countries who completely share the data. We
Hmm.
don't have yet the system. So if patient was seen by a cardiologist and he made him the full list of laboratory testing, and patient come and wants it again, so I can do it again. And it's of course, we lose money that way.
Yeah. I think we pay. I'm not, every insurance company in the United States, because it's private, it has different rules and regulations and what they pay for and how much they pay for. But Medicare will pay for what they now call a wellness exam. They won't call it just a checkup for some
Uh-huh.
reason. And actually, unless there's something wrong with you that the doctor can pinpoint, they won't pay for the blood tests and that are routine with every checkup. So I would say that most people on Medicare have something that is wrong that requires an annual set of blood tests, because that's the way it's set up here, which seems rather inefficient and rather stupid to me. How can you have an exam without blood tests?
Hmm. We have the system of regular health check every 2 years.
Mm.
And we know
Is that
that
for everybody or age
it's for
related?
everybody. It's a universal health check. It doesn't count with risk, and it's just universal check available, accessible for all insured people. But like half of the population attend these checks. So
Hmm.
that's how it works. And there is a paradox, as everywhere, that the more healthy people are rather coming than the people who need it. That's like everywhere. Yeah.
Yeah. How do we deal with that? Because that's part of prevention, isn't it?
Yeah. It's complicated. Yeah, we try to improve this by first the patient or population health awareness or literacy is a little improving. We have our software ambulance system now are able to invite individual patient when they time comes, when they have 2 year period. So they invite them automatically. So
Mhm.
it's helping. We do the same with the screening programs. We have screening for colorectal cancer and for lung cancer and for prostate cancer and all these and mama program, the
Mammograms.
breast
Mammograms.
cancer
Yeah.
program. So the patients are now invited through this ambulance software system. So it's helping, and the number of patient or the coverage of patient for prevention and screening programs is increasing, but still it's not much uh, over 50%.
Well, would you say that people even know that they can get this exam every 2 years? I mean, is it a matter of simply, yeah, I'm signed up with a doctor, and if something's wrong, I know where I can go, but they don't know that they can get the regular checkup?
That's rather philosophical question because some people just easily don't want to be detected by chronic illness. They have project, they build a house, so they say, I come after I make it. So that's individual and free will of people if they go to and we have to respect it. We have to respect it.
Well, I think maybe as time goes by and younger people begin to understand more about health and healthcare, younger people, at least the ones I know, are pretty active. They love to go on, mountain climbing trips and swimming trips or physical trips for their vacations and stuff. Maybe they'll begin to put two and two together as they get older. One question that I ask you, and I kind of ask everybody, we moved, and it has to do with the shortage of doctors and nurses everywhere. We moved many years ago to getting vaccines and other regular shots at the pharmacy level. And I would not dream of going to my doctor for a vaccine shot, or if I needed a routine shot for some other, chronic disease that isn't critical for a doctor to administer. It's all done by mostly the big pharmacy chains here. Their pharmacists are trained to give these shots. You have to fill out the paperwork, even though you've been going every year for a vaccine, and so and so. But they figure that they can train a pharmacist to just give a shot. And it isn't that they prescribe it. You come with your prescription to the pharmacy. And they have like a little clinic in most pharmacies. So you have privacy for this. And, this fall is coming up. I'll get my COVID shot. I'll get my flu shot. Hopefully that's it. And, I'm not going to bother a doctor about that. So, how does it work with you?
That's a very interesting question. In fact, a controversial topic. So that's a good point to speak about it because we just have this kind of discussion.
Hmm.
because now all the vaccination is done either by GP or by special vaccination centers. It was a little different during COVID time. There were more centers providing, but now again, all vaccination, we have obligatory vaccination and non-obligatory vaccination. So all is done like 90% by GPs,
Hmm.
some or pediatrician, and some vaccination is done in centers. And of course, in pharmacies would love to do vaccination. They really struggle for that, but the legislation is against, and we see it as a complicated. So, for example, my society is against this move because we think that this will not increase much the number of people vaccinated, so we have enough capacity even to vaccinate more. But yeah, so that's how the situation is now in Czech Republic.
Yeah, even the kids, they take them to the pharmacy. Like you have to have certain vaccines or vaccinations to get into school. Although that's fading in the United States with things like measles now, which is scary. Well, it's just one thing because time with our doctors is so scarce, and we also have a scarcity. I mean, I think that's true everywhere. You even look at what's going on in the UK right now. The so-called junior doctors, or now they're called resident doctors, as they are in our country. They're going on strike for more money again because they're hospital based for their salary. Here, I guess it's the same thing because you have to have a residency before you can become a full-fledged independent physician. Does it work something the same way in the Czech Republic?
Ah, young doctors who start their career usually start in hospital and they are salaried by hospitals. So that's how it works. But this is different for general practitioners. We are the only discipline which is covered by residency program. So there are some few more like urgent care doctors and pediatricians, but traditionally GPs, like I think last 17 years, are supported through the residency program by state money.
Mm.
So every year state make a selection of accredited practices, and these accredited practices get funds to employ new graduate and pay his salary and to cover his expenses for education and attachments in hospital because the specialization training is ongoing partly by practice and partly in hospitals. So they are, and the specialization training is 3 year to complete 3 years.
Mm.
So these 3 years are covered by residency money. It first it helped a lot to the interest for general practice. So we have I think this general practice is as in medical schools is the second most attractive choice, career choice of students.
Really?
And then it helps to improve the position of GP trainers. They are important now. So that this is one of the good achievement in the Czech Republic.
That's really interesting because I think our residencies are only in hospitals. And they don't really work alone except on routine things. There's usually a credentialed physician to report to, but I don't know of any. I've never gone to my doctor and had somebody sitting there being trained or seen anything like that. It sounds like a really good idea.
Yeah. I
Because,
think in Europe it's like common.
hmm,
The training like this is ongoing in many European countries.
um, what about, I mean, I know if I'm in Prague and we spend a great deal of time in Prague, I know if I'm in Prague and if I had paid for the Czech health system, I would have a good hospital to go to. I would have a good doctor. I would have specialists. What happens if you live out in the villages?
Yeah. Uh, in villages, of course, you have your GP again. So you are registered with your GPs. As in all countries, the assurance of rural care to ensure the dense network of GPs in rural areas is a problem, is a challenge in all countries as well here, but it's still not so bad. So still you can find your doctor in your neighborhood, even in country. And then we know that these country doctors are even more competent. They do more, for example, house calls, and they do more procedures. They do small surgery and other things more than we do in cities and in urban areas. But they
So
have,
they're
they have
more like the original I mean, I call it the original,
absolutely.
but kind of what us older people all grew up with.
Yeah, and they struggle with the availability of specialists, because as is a problem with general practitioners in rural areas, there is even the bigger problem with the specialists
Mm.
available in these areas. So it's really it makes the rural job of GP more challenging.
When I interviewed Dr. Marks for my very first podcast, and he is the go-to person for social health information, teaches at Charles University still. He talked a lot about the rural areas and how there were these small but outdated hospitals that were important to the people who lived in these areas, but that they couldn't possibly afford to update them with the kind of imaging equipment and other equipment that you need in today's medical world. And it was his feeling that they should be made into perhaps rehabilitation homes or something else that's kind of halfway, but that the hospitals should be in the small cities and that it's not that hard to drive there. What is your thought about that?
Ah, from the point of view of primary care, we used to have a doctor in each village. That was the typical for the socialistic era, that it was the like state responsibility to ensure that every village has a doctor. Now with the development in medicine and with all the consequences, we know that it's better to have well-established team of GPs in a bigger village or small town, better equipped team practice than to have a doctor in each village. But that there is a need to educate people in this way, to explain them how it works, because it's a still political question. The successful politician is able to manage GP in a village. So that's and of course the insurance company plays a role, because
Mm.
it is responsible for the network, and so that's very complicated. Yeah.
Um, I think I think sometimes as procedures, medications, all the ultimate things that you have to work with as a physician modernize, people's attitudes toward their physicians just stay the same. We all remember what it was like to be a child. We all hear the stories of our parents, and we kind of want that relationship. In our country, many people have basically no relationship with their primary care doctor. You just go when something's wrong, or you go for your annual, or whatever it might be. But because the amount of time spent with you is so little, a lot of doctors burn out and they just quit at a relatively young age. And you and your doctor never truly get to know each other. And I think that's probably the greatest problem of our time, because if you if your doctor knows you, they have a better chance of helping you prevent diseases as you go on. If you respect your doctor and know him or her, and they say something to you, you're more apt to listen. And I think we've lost that in this country.
Yeah. You probably heard about the Paris project,
Yeah.
the project of international project assessing the patient's experiences and outcomes in primary care. And we were very satisfied and very happy from the results. And the results show that Czech people reported in the highest percentage the relationship with his GP 5 years and 10 years. So we excel in this thing, you know. So it shows that really for people is important to keep this longer relationship. Of course, people move, people have reasons to change doctor. It's happening, but still majority of people is happy to stay with his GP longer time. So I work in the center of Prague, in fact, in Karlín, and I work on the same place for years. And I think as for the cardiologist is the dream of cardiologist was maybe to finish his career in Mayo Clinic or where. So for GP is a dream to start and at the same place. So I completed this dream, and I must say that I even see a third generation of my patients. So
That's amazing.
yeah.
That would be a wonderful thing for those of us in the United States. You explained to me that as a GP, you essentially are a small business that contracts with the insurance company. Is that a correct interpretation?
Yeah, in 90s, where the privacy of practices, the privatization of practices were possible. At that time, nearly 100% of practices were private and single-handed. That's how it started. In fact, like 30 years ago. Now we know that to run a single practice with all the challenges, with the chronic multimorbidity, with aging of people, with many quality measures, and so vaccination, prevention, screening is a very difficult. It's very difficult. So we still have majority of single-handed practices, but more and more people go to team practices, and you were asking about young people and young doctors particularly, and I meet them as 6-year students in at the faculty and the academy, and then later. So the life work balance is one of their priority, I think, as everywhere in the world of this generation. So they don't want much to run their own business. So half of them rather start to be employed, work with other GPs, work in team practices, or allow them to be employed by chains, which are more and more in the primary care market as well. So that's happening in here.
And so what is that going to ultimately do to your vision and your actuality of how healthcare works in the Czech Republic?
Yeah, I definitely think that the team practice is a future
Mm,
because I spend half of my practice time, I work like a sole doctor, single doctor, and the rest I work in a team practice. Now we are six doctors. So it's a completely different job. We enjoy it much more. We can share our patients, speak about them. We can buy a lot of equipment. We can do more advanced medicine, we can easily leave practice for educational purposes, go to congresses, and so we have more staff, more nurses, we have receptionists. So it's really different. I think it's a future of general practice. Yeah.
that's kind of what's happened here, for different reasons. Um, Keeping track of everything for the insurance companies and putting in the right codes and all that kind of thing got to be so difficult, that no one doctor can really do it alone.
Yeah, yeah.
And, they have to hire a person to do that, and that got to be very expensive. So the groups started forming, and now the big hospitals are now in chains, so that essentially a New York hospital might have other hospitals around the area or even out into the Midwest that are part of their hospital chains. And it's all kind of to defray all this expense with and confusion with insurance companies. And also, I think so that information can move around so that a patient who is in a smaller city and might need some kind of expertise that is not so readily available, those all of that information can be electronically transferred, and we even use the telemedicine medicine for that kind of thing, particularly in rural areas. But I don't know. There are specialists who have individual practices, but those specialists are almost all connected to a hospital group. And it's not like they're operating on their own. So I don't think most young doctors could even afford to do it. I mean, it's just, to set up that kind of practice, borrow that kind of money, even buy a practice, which is very common here,
Yeah, yeah.
both for dentists and for physicians. But you got to be able to pay back that loan if you do it. So I think most people who think about going to the doctor or getting some help for some condition don't even think of the problems that a doctor has if they want to open up their own practice.
It's a part of our education, which we as a society deliver to young doctors, and they have their own organization, like sub-organization of young practitioners. So they share this information. So the knowledge and advices for how to start its practice, how to buy the practice, how it's quite available, but to run practice on his or her own, it's quite difficult, and it
Mm.
needs. It's, for example, it's very difficult for women who just left their children and start as more children. So it's difficult. Yeah.
How do you see, I mean, looking forward now, I mean, this is the big question. There are more and more effective drugs, and they cost more and more money. And sometimes that insurance companies aren't willing to pay for. There are more new procedures. There's more new equipment for those procedures. We have a better handle on so many diseases now. But that all costs more and more money. How do you foresee a small country like the Czech Republic, even though you're part of a bigger, European Union organization, changing and adapting to that and still providing the level of care that you've been talking about?
I see the development even in my practice. 40 years ago, I had a stethoscope and blood pressure device, and even 5 years ago, I couldn't not have imagined that I would have an ultrasound in my practice. Now I have, and I have another procedures available, equipment, and so. But the question is how efficiently it is used, and it's around the whole health service. So in fact, hospitals can buy what they want, and the only limitation is whether insurance company would contract this this procedure or this special investigation, MRI, and there are many other procedures. So I think it's a very there is big need for effective management, effective governance of these buying and of these methods, but it's over me. I don't know how to solve it. I have enough to decide what I buy for my practice because I have now more equipment than I can effectively use. So I stop now buying new things.
Mostly, our doctors band together and buy that equipment. You won't find it in most individual offices. The bigger practices with more doctors in it, they will have some of that, but they will go and large groups of doctors band together and buy a lot of imaging equipment, for example, and put it in another building, and then they all use it. But you can't do it at your will. Obviously, there's a time and everything. Or a doctor's group will contract with a hospital group, and then you send your patients to the hospital for the imaging. Doctors band together here and create surgical centers for same-day surgery. And it's funny because you go in as a patient and your doctor has 3 hours to do let's say something simple like straightening a toe if you're a podiatrist or something. And in that 3 hours, he will schedule a bunch of his patients. And then another doctor has the next 3 hours, and then another doctor after that, and you can't step on each other. So there really is this odd sense that's so different that when you go to the hospital for something, and that's a whole different system. So I don't know which one is better, but I do know that smaller doctor groups simply cannot afford to have this equipment.
Yeah. These agreement among bigger number of doctors is not happening here. It's funny, or it's interesting. It was so easy to escape from polyclinics when we were working in 90s and to create our own practice, separate. It was so easy. But now, when we understand that would be again better to join and make bigger groups, it's much more complicated. We too much enjoy our autonomy and individuality that it's very difficult to join again.
Well, it's I think going to come down to financial issues probably everywhere because I don't see medical care getting any cheaper.
Right.
And when you add in prevention, which requires for many people monitoring, I don't know how you can go it alone.
Yeah.
Let's just talk a little, just as we wrap this up, about your responsibilities as a GP. You've already said, that it's changed in the sense that you have this equipment now that you have access to, and it was just a stethoscope and blood pressure cuff. years ago. Where do you see it all going? I mean, do you give it some thought? What is it going to be like in 10 years, 20 years?
Uh, I share the what Wonka says, or Wonka expert says, that for us as for a general practice as a discipline, or for family medicine as a discipline, is important to stay close to patient. So to provide individual care, patient centered, because then we can stay as the only discipline in the system which is behaving like that. So I think this is the future of us, that we will be clever, we will have equipment, we can do things, but we still have time to look to the patient, speak, listen to them, and help him with regard and with respect to his preferences and behaviors and attitudes and so on.
Well, on that note, that's a good place to end. And I think half of America would like to be living in the Czech Republic, based on what you just said. It seems like a little more caring system than we have developed here. Although I'm sure in smaller areas, some of that caring is there. It's just in the bigger city areas, it seems to be more based on money and who gets the money and how it's cut up, than on the patient, him or herself.
And there is one other thing which is also very important. The special Czech Republic, we built a system with the aim to have for each condition, each diagnosis, one doctor. So now in the situation where we have so much chronic multimorbidity, the patient spend whole day to visit his appointed specialist, and the need for coordination of this care never greater. So this is another role of GP, because he has to stay at his place and be coordinating this patient who are confused, who don't understand, who have a list of medicaments which they don't know if they fit together.
Yeah, like I guess you call it morbidities. It's not just one illness. A lot of people end up with several that kind of interact with each other. Well, I thank you very much. It's very interesting. I hope some of the people who have the power to make some changes might listen to people like you and realize that if you have a GP, somebody that you trust, that you can talk to, you're far more likely to think about preventing yourself from getting any sicker than you might be, or not getting sick at all, than if you're just a number in a ledger book, which I think a lot of Americans feel like. And I hope the Czech Republic stays centered with people like you, because I think in the end it's cheaper if you want to just look at it from a financial standpoint.
In my practice, by the way, I have few American people as well, so they look happy with our care. So, yeah.
All right, Bohumil, thank you very much again, and take care.
It was a big pleasure for me. Thank you very much.
Dr. Bohumil Seifert is a general practitioner in Prague, Czech Republic. In addition to his MD, Dr. Seifert also holds a PhD and is an associate professor at the Institute of General Practice, First Faculty of Medicine at Charles University. He headed that department for 14 years until 2023. Dr. Seifert now spends half his time practicing in central Prague, the Czech Republic's capital. The rest of his time is spent in international activities and research, much of it for the World Health Organization and WONCA, the World Organization of Family Doctors. Now, Our next podcast may be a look at why often expensive dental care has never been folded into the general health insurance system, but it may not be. Hey, it's summer. So, check the show notes on my website, which I'll update as soon as possible. As usual, episode 37 will drop on the third Tuesday of September, since I schedule one new podcast episode a month. And because it really matters, please subscribe and share. The video version's on YouTube, audio on Apple, and on all the other major platforms, including my host platform, the Podbeam website, and app. Show notes and links on my website, stephanieshelton.com/conversations. I'm Stephanie Shelton. Take care of yourself and all those you love, and I'll see you next time. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.